This afternoon, I'm going to talk a bit about delirium, which you're probably all fairly familiar with, but it's probably for people that are relatively new to ICM, it's probably worth running through a few things about what delirium is, what the potential causes are, what the effects on patients are, what the effects on caregivers and families are, and how we can monitor it, how we can diagnose it, and how we can minimize its effects. So you don't usually get through a handover without someone saying that a patient has been delirious overnight, typically at night. So-and-so's had to have more sedation because they were agitated, they were delirious. So it's a common problem that we face. And the definition of delirium from the American DSM-4 manual, which is the official sort of list of mental disorders, is that it's a disturbance of consciousness with inattention accompanied by changes in cognition or perceptual disturbance that develops over a short period of time and fluctuates over time. So what are the features? Well, as that DSM definition suggests, there is a disturbed level of consciousness. So that might be a sort of heightened level of consciousness or agitation, or it might be that the patient is lying there very quietly, may even develop into coma. It's associated with an inability or a reduced ability to maintain attention or to sustain attention or even to shift attention from one task or one thing to another. And also the patients frequently report a change in understanding of their environment, or they develop hallucinations, so perceptual disturbance. And again, if you talk to patients who have delirium, or you talk to patients who have suffered delirium, who remember it, then they often have this idea of nightmares, of things attacking them. There was a very good description given by someone who was an intensivist who had major surgery, and they were in an upper floor room in an American hospital. And when they woke from surgery and they had lines and stomas and they were in pain and sedated, they described floating above their bed, going through the window, falling to the ground, and then having to collect all the parts of their body to put them back together so that they could climb up back into bed. So it can be very real and it can be very frightening. The motoric features, or the various, what we observe from the end of the bed, really can be broken down into three major types. We all are very good at recognizing hyperactive delirium, where the patient is very agitated, can be aggressive, pulling lines out, attacking people around them, they're disorientated, and they are having hallucinations. In fact, that pure hyperactive delirium is relatively rare. Much more dangerous is hypoactive delirium, and it's dangerous because we don't recognize it and we don't pay it the same attention as the patients that are hyperactive. So the hypoactive delirium patient will lie very quietly in bed. They'll be very withdrawn, lethargic, and not really interacting with their environment. And from the end of bed, you think, oh, yeah, they're a bit sleepy and they're just, they're lying there nice and peacefully and they're not causing any trouble to the nurses and everything is fine. But they may actually be suffering quite considerably internally. So they may actually have all these hallucinations, but just appear perfectly calm on the outside. By far the commonest type of delirium is actually a mixed picture. And they fluctuate between the hypoactive and the hyperactive types. And we observe those and we diagnose those and we lump them together with the hyperactive because we just see the hyperactive parts of their delirium. And that's why we tend to think that hyperactive is on its own more common, but in fact that is very unlikely to be pure hyperactive delirium. So the prevalence in intensive care patients varies a little bit depending on your population, but it's been reported as being anything from 32 to 87% of patients, which is an enormous number if you think of the number of patients who pass through our unit every year. And you know, there's a lot of those are going to be delirious. Being intubated, so as a level 3 patient, your risk is significantly higher than in the non-intubated patient group. And again, this may just represent something to do with disease severity rather than intubation per se, although intubated patients tend to have more heavy sedation, and we know that that's a risk factor. And we'll come back to that in a little while. Delirium is much more common in an older patient group, sicker patient group, so patients with high Apache scores will tend to have more delirium. Patients with sepsis, and patients who are encephalopathic for other reasons. So, you know, in our patient group, we see a lot of patients with alcohol-induced encephalopathies, but, you know, metabolic encephalopathies as well, and sedation-related encephalopathies. There are a number of phenotypes, delirium. So if you think of it as phenotypes as causative types or what we observe. So very commonly, it is associated with sedation. And this is sometimes associated with relatively short-term and reversible delirium. When you reduce the patient's sedation or you modify the agents you're using, it may improve. Hypoxia, and not only hypoxia in terms of delivered PeO2 to the brain, but also hypotension, so relative hypoperfusion of the brain is a major cause. Sepsis, so being defined as the suspected infection in two of the old-fashioned SIRS criteria. Metabolic, again, major disturbances, and we know that it goes with patients with very high urea or significant other electrolyte disturbances, so particularly around sodium in the extremes of hypo and hypernatremia, and also in patients with significant liver dysfunction, so with raised ALTs, or patients who have been hypoglycemic. And then there's a very large unclassified group which sort of muddles everything else that our patients have together. So what are the major risk factors for delirium? So we've got age as a very major and probably the biggest risk factor in terms of pure patient factors, but also alcohol use, nicotine use, and increasingly other drug use. So we're seeing increasing numbers of patients who are chronic users of cocaine and cannabis, etc. In terms of chronic health, dementia, pre-existing dementia prior to coming to ICU is a very major contributor to delirium. Patients who have been previously hypertensive, and you could postulate that a lot of our patients who have chronic hypertension then have periods of relative hypotension. And as I mentioned before, that could be a major cause. So if you're already hypertensive, your ability to deal with periods of hypotension, either disease or sedation induced, are much less, and you're much more prone to develop the cerebral changes associated with delirium. Patients with underlying cardiac disease, particularly patients who have suffered myocardial infarction, are at high risk, as are all patients who are generally sicker, so patients who are at the higher end of the ASA scale. In the acute situation, patients who have suffered coma for whatever reason are at risk. Patients, as I mentioned before, with higher Apache 2 scores, patients who are really undergoing emergency surgery because they tend to be sicker, patients who are ventilated, patients who have suffered polytrauma, severe metabolic dysfunction, particularly in the form of acidemia, patients with fevers and organ failures. So all those are things that we intuitively know from our experience with delirium, that those are major risk factors. The environment and what we do to patients also has a very major part to play. Particularly at the Royal, if you're joining us from Glenfield, you don't experience the lack of daylight quite to the extent that we do at the Royal. But having no daylight, having that loss of day-night change is a big contributor. Drugs that we give patients, benzodiazepines, are extremely high risk for precipitating delirium, opiates as well. Any form of physical restraint, and so it's interesting here that it's defined as epidural analgesia is associated with an increase in delirium over patients that have just had spinal analgesia. And that is partly because you tend to tie the patient down to the bed with an epidural, they're not mobile. We also restrict patients, both in terms chemically, but some countries physically. And we also restrict patients by putting things like catheters and lines in them so they can't actually get out of bed and move around. Patients who are in isolation, so patients who are in side rooms with very little interaction, are at higher risk. And actually not giving people normal food as well. So if you're continuously tube fed or on TPN, that will be a risk. So we know that all those are risk factors, but what is it that actually causes delirium? Well, it certainly has a physical manifestation in terms of, if we look at patients who are delirious, it seems to inform some form of neuroinflammatory response. And certainly these patients have elevated levels of S100B, and that's a marker of glial activation. And you see those elevations as well in patients with neurotrauma or hypoxic brain injuries or encephalopathies. They may also demonstrate elevated CRP or elevated procalcitonin. Again, not really particularly as markers of infection, but as markers of inflammation. And CT and MRI imaging and PET imaging of patients with delirium compared to patients without delirium from a similar sort of otherwise physical set, they show some damage in around the posterior parietal regions and prefrontal regions, and also around the basal ganglia and the thalamus and the temporal occipital cortex. And those have been demonstrated quite clearly in numerous studies. So it has a real physical basis. It's important because your risk ratio for death, if you suffered delirium, is significantly higher. So there's a risk ratio of 2.2 compared to patients who never have delirium in a matched group. There's a very significant increase in mortality by the end of 6 months, so the post-ICU survival is affected. And there's a very significant impact on long-term cognitive dysfunction. And that is a major contribution to the sort of post-intensive care syndrome. And Cass Sampson gave an excellent presentation in this series some time ago on that, and that's worth looking up if you didn't see it. And delirium has a major cost, and the cost in the USA, and this is data that's about 6 years old, is estimated from anything from $4 to $16 billion a year. So it has a major social impact. So these are some. These are some Kaplan-Meier survival curves of patients who have delirium. So the upper one basically divides it into patients who had delirium from all causes and against patients who never had delirium. And you can see that the lower line is the delirious patients. So you can see going out to 6 months, that difference in survival. The second graph divides that a little bit more into patients who, so the patients who never had delirium, so dividing those patients into patients who had coma and those patients who didn't have coma. The ones who had coma had a high mortality. But again, it's even more marked in the delirium group. So delirium plus coma leads to much worse outcomes. So I mentioned long-term cognitive dysfunction, and you know, oops, it keeps doing its own thing. Yeah, long-term cognitive dysfunction. So about 25% of ICU survivors will have cognitive impairment at 1 year. A lot of them will have developed what's now known as ICU syndrome. And this has a major effect not only on the individual and their ability to return to work or integrate into society, but has major effects on their families and caregivers as well. People who were previously independent become dependent. They can no longer, they may need long-term care. They may they may not go back to their previous home setting. For younger patients, they may not be able to go back to meaningful economic activity. So this is really, really important to families, and this is why delirium is so important. We get people physically better, but they end up socially wrecked. So delirium is probably the biggest risk factor in the development of ICU syndrome. And various studies have shown that this is particularly marked in patients who have suffered from ARDS. And we probably saw some of this during COVID. The duration of sedation analgesia, however, are not really very good predictors of their long-term cognitive dysfunction. So how do we diagnose delirium? So, we know it's really bad. We know there's a lot of high-risk groups, but if we're going to do something about it, we need to be able to diagnose those patients that have it. So patients should really have daily or possibly more frequent screening for delirium. There's been a number of things that have been suggested for this. The one most commonly used is the CAM-ICU, which is the confusion assessment method, the ICU. And also there is also an intensive care delirium screening checklist, but the CAM-ICU is probably the most reproducible technique, and it's the one we use on the unit here. So the sensitivity of CAM-ICU is anything from 93 to 100%, and its specificity is about 98 to 100%, so pretty good. And it's been validated for use in patients who are non-verbal. Most of the other screening tools need the patient to be verbal in some way. So the 4AT, for example, they need to be able to interact verbally. The CAM-ICU don't. It is used daily, as I say, or can be done more frequently than that, and it can be easily administered at the bedside. So here is the CAM-ICU screening tool, and it's divided into a number of stages. So looking at, has there been a change in their conscious function? Then we can look at inattention, and then look at whether they have the ability to actually think logically. So it's a bit of a dull slide, so I'm going to hopefully, if this works, show you a short video on the CAM ICU. So this has been recorded in Watford by Valerie Page, who has done a lot of work on delirium. There's a bit of background noise on it. It's recorded in the middle of their ICU, but hopefully this will play. What about, we diagnose delirium, but how do we prevent it? So important is the proper use of sedation, the proper use of analgesia. And so the use of proper sedation analgesia guidelines in UHL, we have our own PAD guidelines. The Society of Critical Care Medicine in the States has advocated the use of the ABCDEF bundle, which I will come to shortly. And Scotland, they produced a signed guideline on delirium management. Pain, agitation, and delirium, our own guideline, very similar to other national guidelines, but basically we need to differentiate between agitation in the ICU patient and delirium. And not every agitated patient has delirium. Patients be agitated because they are distressed in other ways. They might have pain. They might be anxious. And the other thing that use of sedation guidelines mandates is the use of sedation scoring to titrate sedation to an appropriate level. Think about potential causes of delirium. And this is taken from the UHL delirium guidelines, which are ward-based. But actually, in terms of intensive care, there's a nice mnemonic on ICU deliriums. And these go through potential causes to think about if you're faced with a delirious patient. So iatrogenic exposure. So that's not just drugs and stuff that we give people, but it's actually what we do to them, in terms of surgery, in terms of invasive procedures. Cognitive impairment. Do they have pre-existing cognitive impairment? Do they have pre-existing dementia, for example? As I mentioned before, restraining patients, and even if that's restraint by use of things like urinary catheters, that could be a potent trigger. Drugs are probably the biggest thing that we do to people that cause delirium, and in particular, benzodiazepines are particularly harmful and deliriogenic, and particularly long-acting benzodiazepines. As I mentioned before, the elderly are at risk on those patients that have had significant metabolic dysfunction and abnormalities in their blood chemistry. Infection, sepsis, big risk. Respiratory failure, and we know that ARDS patients are at particular risk of developing delirium. Intracranial perfusion, so anything affecting intracranial perfusion, be that hypotension, be that brain injury, or brain infection, stroke, then that will all be deliriogenic. Urinary retention, so blocked catheters and fecal impaction are potent, as myocardial dysfunction. And also sleep and sensory deprivation. We're very good at denying people sleep. It's often a noisy environment. It's a light environment. We deprive people of their normal daylight rhythm. They don't know where they are. So think about all those things. When titrating sedation, we're mandated to do it to use the least sedation possible to produce a patient who is comfortable, but ideally calm. So we measure this using the RASS, the Richmond Agitation Sedation Scale, which goes from +4 all the way down to -3. We want to keep people ideally anywhere between -1 and +1. A patient who is absolutely deeply sedated, -4, -5, is at risk and at risk of harm. Now, there might occasionally be a good reason for doing that in terms of neuroprotection or in patients who are particularly difficult to ventilate. However, the ideal is to have patients much more alert than that. So the SCCM produced an ABCDEF approach in the management of delirium. So part of that is to look at the things we've talked about: pain, agitation, and delirium. So, trying to keep patients comfortable, so treating their pain, so giving them adequate analgesia without over sedation. If they're agitated to a point of being distressed or it makes their management impossible, then appropriate use of sedation to maintain the RASS to produce a sort of calm but comfortable patient. These need monitoring and also monitoring for their state of delirium, so the CAM ICU. So in terms of the care approach, so assessing and treating pain, very important, and the Americans seem to think they discovered this, but in Europe we've been doing this for a lot longer, allowing patients daily awakening trials. So sedation holds should be the norm. Spontaneous breathing trials should be the norm. So actually aiming to keep people on the ventilator for as short a time as possible. Trying to coordinate care so that patients aren't constantly being attacked by various groups of people. So the physios come along and then the speech therapists come along and do a bit, and the OTs come along. Trying to coordinate care so the patient does have some periods of adequate rest as well. As I said, sedative choice is important, and delirium reduction. So trying to promote normal sleep, trying to promote orientation. So make sure patients have their glasses, make sure patients have their hearing aids. Do they have impacted earwax that they can't hear? Do they know what day it is? Do they know what time it is? Early mobilization is really important, and exercise. And probably the real key to a lot of this is the family, and having the family involved in the patient's care. And it also helps with that transition from ICU to the ward to home. So sedation and analgesia choices are important. So we want to have patients that are comfortable, but with a minimal dose of analgesia. Avoid benzodiazepines if possible. There's been a lot of debate as to what the ideal sedative agent would be, whether it be propofol. We use a lot of propofol, although that in itself may have disadvantages in long-term use. And also we increasingly use alpha-2 agonists. In general, we use clonidine, or more recently dexmedetomidine. Dexmedetomidine has been more commonly used around the world before it was used in the UK. But alpha-2 agonists may offer some protection against delirium. SPICE-3 trial, which compared alpha-2 agonists with propofol, had a number of faults in the trial, and it wasn't really powered to adequately to show the effects on delirium. But the signal was there that perhaps alpha-2 agonists are less deliriogenic. There's some recent trial work on the A2B trial, looking at the differences between clonidine and dexmedetomidine. And there may be, certainly in younger patients, there appears to be a higher incidence of side effects with dexmedetomidine. So clonidine may be a cheaper and possibly more effective alternative. There's no evidence for giving haloperidol prophylactically for prevention of delirium or even for treatment of delirium, but it is actually quite useful at reducing the harms to patients who are very agitated. So if you have an agitated patient, it's safer to give them haloperidol than lorazepam, for example. Lorazepam is much more likely to generate delirium than haloperidol is. And there's also some evidence that olanzapine may be useful in prevention of delirium and management of delirium, and that's something that we do. We do use melatonin occasionally to promote sleep-wake cycles. It appears to be relatively safe, but again, there's no specific evidence for it in the management of delirium. So that sort of summarizes the ABCDEF approach, and the reference I'll give at the end, there's a lot more detail that you can go and have a look at on there. What about non-pharmacological interventions? Well, these are, if you like, probably more effective and important than any drugs that we give patients. So repeated reorientation of patients to where they are and when it is and why they're there. Give patients something to do, cognitively stimulating, and our OT team and our support team are really good at that, and the sort of meaningful activities we can give patients. Trying to improve sleep through non-pharmacological means, so our leaving patients alone at night, turning the lights down, keeping the place quiet at night. The amount of noise in the main unit is phenomenal, particularly if you're in one of the beds next to the central station where the alarms and phones ring all night. Getting patients mobilized early, trying to take things like catheters out so they're not tied down, and making sure they have their normal aids like their normal glasses, giving them magnifiers if they need that to help them read, making sure they have their hearing aids, so that it can be very disorientating if you don't have those things and you normally rely on them. Making sure they're adequately hydrated, keeping them pain-free, and sort of minimalizing interventions. So, we have other non-pharmacological interventions. Here's Scylla, she's very important, member of the team, has her own badge. And our environment is really important. So if you were here during COVID, you'll know we had a number of patients who were in the pediatric recovery area, and they woke up to see that. And it wasn't surprising that they woke up somewhat delirious when all they could see were space monsters and rockets. Family involvement is really helpful. It helps orientate the patient. It's very instructive to the family about what's happening. Families can assist with caregiving and mobilization. Now, we have a very small unit, and one of the problems with that is there's not a lot of space for mobilizing people. It also helps manage family expectations about recovery. And involvement of the family gives you a picture of what the patient was like beforehand. And it puts in place the best possible support for when they're finally discharged. So we had a very good model of what happens when you don't do all these good things during COVID. So the incidence of delirium in COVID increased significantly. It was a French study that showed it was about 80% in those patients who were ventilated. Patients tended to be a bit more agitated. We tended to sedate them more heavily, and largely that was due to having fewer ICU trained staff at the bedside. It was due to the difficulties in ventilating people. It was due to the fact we had people prone, and it was to keep them safe in the short term, although it may have led to more delirium in the long term. And the normal ABCDEF protocols were impossible to implement. You couldn't have relatives inside the unit to help. And doing a lot of things we normally do or would want to do became very difficult. And that was reflected in a higher incidence of delirium, probably a higher incidence of PTSD in COVID survivors. So in summary, delirium is bad for patients, obviously. It's bad for their families, bad for society in general, bad for the economy. It's bad for us. They're difficult patients to look after. It's not very well understood, despite quite a lot of research. It perhaps doesn't attract the research that goes into sepsis and other more potentially exciting areas of intensive care medicine. There is no one drug or magic bullet to stop it, to cure it. And actually, once it's occurred, it's very difficult to treat. So trying to prevent it through an ABCDEF approach and proper sedation guidelines is important. And it really does require multidisciplinary intervention from all of our colleagues in the unit, but also from families to help. There is an excellent online resource to do with delirium, icudelirium.org. And this has got a huge amount of information and practical information on the management of delirium. It's been put together at Vanderbilt University in Tennessee, otherwise Ely. And there's some really good videos and really good resources available on there. Okay, I'm going to depart. Have a good weekend.
Thank you.